Hello, let's talk about coagulopathies, tendencies to clot. When you get a venous clot, it typically occurs in the deep veins of the lower legs because of the degree of stasis in those veins. They have to work against gravity to get blood back up to your thorax. And the femoral vein, albeit larger, is another spot where clots like to form. So when you get a clot in the lower legs, what next? What does it do? Well, clots tend to embolize or just break off of the wall where they form and travel elsewhere in the bloodstream. And they tend to like to go into the lungs. That's the pulmonary embolus. So, most pulmonary embolisms, like 80% of them, go undiagnosed because there'll be little small things, little tiny clots that just block off one part of one lobe of one lung. And so typically patients' lungs are healthy enough to where they don't even notice the fact that they just got a pulmonary embolism. But certain pulmonary emboli are very, very lethal, such as the saddle embolus. You get that and you're just about dead on contact because that's going to obstruct both pulmonary veins. And so think about your VQ ratio, ventilation over perfusion. Perfusion drops to 0 if you're occluding both veins, and you're not going to live very long without oxygen in your blood. And smokers also, and patients with existing lung diseases, obstructive or restrictive patterns, both, are going to be more prone to become symptomatic following an episodic pulmonary embolus. So the pulmonary embolus is going to be the chief presentation of these coagulopathies along with the DVT, which could lead to a little bit of venous infection. That would be called a thrombophlebitis, right? Where you've got inflammation of a vein along the walls of that vein. It's going to get red and you'll be able to see that on the skin visibly, kind of like a red tract. Just like that one pathogen, Sporothrix, that likes to get into the lymphatics. And you'll look at the patient's arm and there'll be a red track just going up the arm along the lymphatics. That's exactly what a thrombophlebitis looks like visually on PE. So those are some common manifestations of coagulopathies, and we like to categorize them as familial or acquired. That's a good way to think about them. So in this SDL, we start with the familial coagulopathies. And many of them have to do with chemicals in and around the coagulation cascade. Understand that when we're talking about forming a clot, first thing that happens always is a platelet plug. Second thing that happens after that always is the coagulation cascade, which throws fibrin on top of the platelet plug, cross-links it up, and stabilizes it. So everything you see in this image is occurring after platelets have done all their work. Got it? Okay. So then breaking down the factors and the pathways, understand that 10 is where we start to go to the common pathway. Extrinsic pathway, we measure that with PT, and that's just factor 7 and tissue factor. And so the test for PT, that's prothrombin time, all that we do is we take patient's blood and we add some tissue factor into that sample of blood and just put a stopwatch on it, see how long it takes to clot. So similarly, for the intrinsic pathway, we measure this with partial thromboplastin time, that's PTT. How do we perform this test? Very similarly, again, you need phospholipid to finish off the intrinsic pathway. So in the PTT test, all we do is take a sample of the patient's blood, put some phospholipid in it, and wait and start a stopwatch and see how long it takes for it to clot. And that's your PTT. Now, both of these tests, PT and PTT, will be prolonged when the patient is taking heparin or warfarin. There's a difference in the tests that we use to monitor each drug. Particularly, we'll use partial thromboplastin time and measure the intrinsic pathway if we want to see how heparin is doing, if the patient's on an appropriate amount of the drug. And we'll look at prothrombin time, PT, if we want to analyze how a patient's doing on warfarin, i.e., do they need more or less of the drug? And I figured out the reason why we do this particularly for warfarin, is because warfarin inactivates which factors? Well, 2, 7, 9, and 10. So out of those, 7 is going to be the very first factor that warfarin inactivates. And so that's why we use the concentration of 7 in the extrinsic pathway as our measure of how well warfarin is functioning in a patient. Now, everything else in this chart is really it's a repetition type thing. There's no easy way, no good way. Hell, why would you want to learn all this in one go? You know, it's like, are you going to need all of it at once? No. And so learn it as you go and learn what you need to associate with different diseases, because that's really what's going to put it in your memory. Let's start off with antithrombin deficiency. Antithrombin, I want you to think about it like this. Antithrombin is a basketball player, okay? Heparin's the coach. Okay. Now, a good player with a good coach, like, oh, watch out. But a good player with a bad coach has no clue what he's doing and doesn't know what adjustments he needs to make, okay? So what I'm saying is that a good coach takes a good player, makes that much better. So that's what heparin does to antithrombin. Heparin doesn't prevent anything from clotting. That's antithrombin's job. Antithrombin is the dude on the court getting the points, getting the blocks, getting the boards, passing the ball, dribbling. Everything that is anticoagulation is antithrombin. Heparin's not doing any of that, but heparin is accelerating the rate at which antithrombin works. So if you have an antithrombin deficiency, what that means is that we can give you heparin, but it won't do anything at all because heparin works on antithrombin. The classic patient with an antithrombin deficiency is one who you give some heparin and you measure the PTT. And it's like, okay, same as before we gave him some heparin. So you give a little bit more heparin, then you measure the PTT again. And it's the exact same. So you're sitting there thinking, man, we have given this guy all the heparin that we can find. Why is the PTT not going up? The answer is because they don't have a lot of antithrombin, and heparin works on antithrombin. Now, this is an autosomal dominant disease, meaning you just need 1 out of 2 potential alleles to have the deficiency or have the disease. And I would also like to point out that antithrombin does a lot of work. So it's an anticoagulant. It's vitamin K independent, so warfarin doesn't work on it. And it inhibits coagulation because it's going to lyse serine proteases. So it's going to cut proteases apart and stop them from working. Now, wouldn't you know, every clotting factor that you have besides factor 5 and factor 8 is a serine protease. So antithrombin gets rid of all factors except for 5 and 8. Now, because it's a protease, it's made in the liver, and that gene, SERPINC1, should remind you of another protease that's made in the liver. I'm thinking alpha-1 antitrypsin, that's the SERPINA1 gene. And if you don't have alpha-1 antitrypsin, remember that's also neutrophil elastase. Well, that's going to inhibit neutrophil elastase rather, because it's an antitrypsin. And so patients with antitrypsin deficiency, their lungs, they get all torn up because neutrophils just cut apart the elastic tissue in the lungs. So we've seen a protease inhibitor before, so you know what antithrombin is doing because you've already seen what it does. Again, it's autosomal dominant. And what's the test for antithrombin activity? Real easy, the antithrombin heparin assay. So in a test question, it'll be kind of evident that they're steering in this direction. Just remember that antithrombin is the protein that heparin interacts with, and you'll remember patients with antithrombin deficiency are refractory to increased heparin doses. Now let's talk a little bit about warfarin. Warfarin, or Coumadin, is a vitamin K oxidoreductase inhibitor. And it's going to knock out factors 2, 7, 9, and 10 alongside protein C and protein S. So warfarin is getting rid of 4 different clotting factors, but it's also getting rid of protein C and protein S. What do those do? Well, protein C and S are anticoagulants. So they will encourage bleeding. That means that if you take them out, you'll clot. Now, wouldn't you know it, when you give someone warfarin, the very first protein that just falls off the face of the earth, you stop making it, is protein C. So that means that before warfarin really kicks in and you're inhibiting factors 2, 7, 9, and 10, before you get to that point, you're going to go through a transitory hypercoagulable state. And it's because you're missing protein C for a really short amount of time relative to all your other clotting factors. Now, that's why we typically give a heparin bridge whenever we want to start somebody on warfarin therapy to defend against the clotting that comes along with protein C deficiency and protein S deficiency. Now, protein C deficiency, well, warfarin gives you an acquired protein C deficiency, but you can also inherit a familial form of protein C deficiency, which, as you can imagine, if somebody has got a genetic lack of protein C, it's missing activity, and you put them on warfarin, for that little period where protein C is very, very downregulated, that patient is going to clot like crazy when you put them on warfarin. And that's why patients with protein C or protein S, which does virtually the same thing, patients with deficiencies in these anticoagulatory proteins, when you put them on warfarin, they're going to clot everywhere. And that's why these patients are more prone to get necrosis, skin necrosis, warfarin skin necrosis. So protein C, protein S deficiency predisposes you to get skin necrosis if you're put on warfarin. So what do protein C and protein S do physiologically? Well, remember that antithrombin is LeBron James out here, balling, getting all the points, all the stats, triple-double this, triple-double that, except there's two clotting factors that antithrombin can't do anything about. So it's a serine protease. It's going to cut apart other serine proteases, and everything except 5 and 8 antithrombin works on. So that means antithrombin is not your guy if you want to get rid of factor 5 or factor 8 in the blood. You need protein C to do that. So that's the physiologic role of protein C and S. They inactivate the two clotting factors that antithrombin cannot do anything about. If you have a familial protein C or S deficiency, you're prone to clotting diseases. First and foremost, most common, the DVT likes to start in those deep veins of the legs, likes to embolize to the femoral veins, likes to embolize again to the lungs. And if you have an ASD or a VSD and you're unfortunate, it could potentially embolize up to your brain, down to your kidney, wherever it wants to in arterial circulation. So anybody who has a familial coagulopathy can get a DVT. I want you to take that away. That is a non-specific symptom that will be right at the front of a question stem to tell you, oh, this patient has a coagulopathy. More particular to protein C and protein S deficiency are going to be two different things. First, neonate purpura fulminans. So when the kid's born, they immediately, fulminantly get purpura, which is going to be a widespread purple-red rash. And this purpura is going to degrade into a black eschar of necrotic tissue. That's really bad. So why are they getting this purpura? Well, because they've got small clots going into the small vessels that are close to the skin and preventing oxygen from getting to the skin, because the arterioles and the veins that go to and from the skin are going to be blocked off by clots. That's your skin necrosis in this setting. And again, if it happens in the kid, neonate purpura fulminans, protein C and protein S. If it happens in an adult taking warfarin, you know it's because of the warfarin, and you suspect protein C deficiency because you know that protein C is the very first protein that warfarin eradicates from the blood. It's going to inhibit production of protein C. So when protein C is down, patients are more prone to clot, leading to skin necrosis, again, because you're going to be blocking off with thrombi all sorts of arteries going to the skin and veins going away from the skin, and that's going to create several territories of skin necrosis around the body due to hypoxia. So you see warfarin-induced skin necrosis, and what do you do about it? Well, here it is. Notice it goes within the span of a day or two from this kind of flat purpurous lesion to straight up necrosis, very gangrenous tissue, very worrying to a patient and their family. And again, you see this, what's the first thing that you do? I hope you thought to yourself, pull them off warfarin, because that's the first thing I would do. There is a very limited differential for warfarin skin necrosis. There is not a lot of other things that this could be. Could it be a compartment syndrome? Sure. Could it be maybe a venous gangrene in a diabetic especially? Oh, sure, it could be gangrene. But if it's on multiple spots throughout the body and it seems to be more systemic than just a localized episode of gangrene, it's warfarin skin necrosis to me until proven otherwise, which means when I look down and I see the patient is on warfarin, then I look back up and I see the patient, I'm like, all right, we're stopping your warfarin right now. So then what's your next step after that? Well, you rack your doctor brain because you went to med school, right? You got one of those. And so you think, gee, what is warfarin deplete? And then you say, well, protein C is gone, and that's an anticoagulant. And so is protein S, and that's also an anticoagulant. But you know, it's a vitamin K something inhibitor. And so you say, oh, if this patient got some vitamin K, it would probably help too. So you're going to want to transfuse them with all the things that warfarin takes out. So you want to get some fresh frozen plasma into them to get their factors back up and their protein C and S back up. And you're also going to want to get some vitamin K in them IV. And you'll want to start heparin just because, well, they were on warfarin for a reason, right? So you don't want to totally anticoagulate them. And heparin is going to help the fact that this necrosis is due to what? Clots. You've got thromboses all over the body. So the heparin is probably going to help that out a little bit too. So a lot of things you got to get the ball rolling on when you notice this, because it can go downhill very, very quickly. Other good treatments that I've glanced at are going to be like factor 10 inhibitors, like rivaroxaban is an example of that. And just other things that anticoagulate in general. This is, if there's ever a time to use more than one anticoagulant, this is it. So that's warfarin skin necrosis, can be due to a protein C or a protein S deficiency. So I'm going to skip over protein S because it's basically the same thing as a protein C deficiency. Now, factor V Leiden, can't skip over that. Very common, very, very common cause of hypercoagulability, occurring in 5.2% of the general population. It's the most common cause of inherited thrombophilia. So it's a gene, it's factor V. Factor V, what does that do? Let's go back to the drawing board. Factor V is right here, converting factor 10 into its activated form. So you need activated 10 and activated 5 in order to take prothrombin to thrombin, which is activated 2. Rewind that, say that one more time. You need activated 10 and activated 5 to take prothrombin to thrombin. And that's it. That's all that factor V does. So in factor V Leiden, you have a version of factor V that cannot be inactivated. Well, turn down for what? I think that's Lil Jon. You know, it's that. It can't turn down. It's factor V Leiden. It can't get switched off. And so it's always on. All the way turned up. That's another good one. Who is that? God, I can't remember who sings that one. So if factor V is always on, then you're always making thrombin and you're always clotting. Does that make sense? Why this is a coagulopathy now? Hope so. So what's the mutation? You might get asked about this. This might get woven into a test question sometime. And it's a single point mutation, a single nucleotide polymorphism. with an arginine to glutamine substitution at amino acid 506. The good news is that's so peculiar that like you don't even really have to memorize it, because anytime you read that, you're going to be like, oh, factor 5 Leiden. That's the only place I've ever seen arginine to glutamine at 506. So not much else competing for that thing in your brain space. That's the good news. And again, it's going to cause factor 5 to stick around in the blood for a long, long time, which is going to increase activation of factor 2, which is going to make you clot. There we go. It's that simple. So you can measure this in the blood via an elevated D-dimer. That just means there's a lot of clotting cascade activity ongoing in the blood. And what's the symptom you typically get? The DVT with or without pulmonary thromboembolism. So if a person in their 30s presents with a bad pulmonary embolism, you're suspicious for a familial coagulopathy such as factor 5 Leiden. And in fact, factor 5 Leiden would be the most common. Now we've got a prothrombin 20210 mutation. It's a point mutation that's going to overactivate thrombin, prothrombin rather. That's it. So it's going to make it easier to activate factor 2, and you're going to clot on the other side of that, just like everything else here. It's autosomal dominant, just like everything else in this section. You're going to see a pulmonary embolism, most likely presentation, or a DVT. So those are heritable hypercoagulabilities. Sometimes, however, a disease process may result in coagulopathy, thrombophilia, the tendency to clot. And now we're going to talk about a few of those acquired processes. First, there's cancer. I want to go ahead and get this out of the way because it's the most common. Cancer makes you clot. And understand tissue factor is the reason why. So cancerous cells very often just spit a bunch of tissue factor into the blood. What does tissue factor do? Well, tissue factor activates the extrinsic pathway. Right here, left side of the screen, look at this. Tissue factor activating factor 7, leading to the activation of factor 10. So the more tissue factor you have in the bloodstream, the more you're going to be clotting. And tissue factor likes to adhere to exposed endothelium, which, isn't a problem in like a 10-year-old. Like, they have the healthiest blood vessels, there's like no endothelial damage. But in a 60-year-old and a 70-year-old who has accrued decades of atherosclerotic damage, tissue factor gets into the bloodstream and says, man, I can't decide. It's like, which one of my cars do I drive today? It's like, what artery am I going to bind to now? I don't know, because there's so many damaged arteries in the elderly that it's like tissue factor can go wherever it wants in the body. And wherever it wants to go, it can cause the generation of a thrombus on top of an atherosclerotic lesion. So tissue factor is responsible for the tendency to clot in cancers. And you can also see this one thing in adenocarcinomas called Trousseau syndrome, which is a migratory thrombophlebitis. So thrombophlebitis, itis means inflammation, and then it's going to be inflammation of a vein, essentially. But the migratory component, what does that mean? Well, it means the patient might have a thrombophlebitis on the lateral aspect of their right calf one day. And then a couple days later, it's gone. But then the next week, they've got one on the medial aspect of their left thigh. And then you're like, that's really weird. Same exact disease, thrombophlebitis, just in a different spot of the body. So that should be ringing bells for you. Oh, that is a migratory thrombophlebitis. And easier way to say that is Trousseau syndrome, which is associated with adenocarcinomas. So what are some organs that like to get adenocarcinomas? First off, an adenocarcinoma is a glandular cancer. It's a malignant cancer too. So the pancreas, 98% of pancreatic cancers are adenocarcinomas. What else do we have? The stomach. over 9 out of 10 gastric cancers are adenocarcinomas. And also the ovaries. The ovarian cyst adenocarcinoma, very common ovarian tumor. So there's 3 organs right off the bat that like to give you glandular malignant cancers that will give you this Trousseau syndrome sometimes, presenting as a migratory thrombophlebitis. A couple other pictures of it. Notice that kind of like sporothrix, it's just tracing the distribution of a vein up the leg. And again, this is following adenocarcinomas. Here's the practice question I got for Trousseau syndrome. A 62-year-old man complaining of lethargy, abdominal and back pain, and some jaundice. He's lost 10 pounds, so you know he's got a cancer. And then you palpate a non-tender mass in the right upper quadrant, so you know he's got a cancer. And then additionally, they tell you he's got erythema and tenderness of the left leg with a palpable cord-like vein. So his left leg hurts and it's red and the vein is inflamed. And then they ask you, what's the embryonic structure that the organ that developed the cancer came from? So that's just one way they can test you on Trousseau syndrome. Again, in this question, they're looking to see, do you know it's an adenocarcinoma particularly? So only glandular cancers, for whatever reason, are related to this migratory thrombophlebitis. Now, cancers can also cause, cancers cause thrombosis. They cause you to clot, and this can present in a variety of ways, Trousseau syndrome being one. So what are some other ways that cancers can present with clots? One of them would be non-bacterial endocarditis. So that could be pretty bad if you get some vegetations, pop off and go to the brain. That's a potential source of stroke. DIC, what does that look like? Well, the patient is going to be bleeding a whole lot out of any open wound because they're all out of clotting factors and platelets. They also have a thrombocytopenia and a factor deficiency because they've also got clots everywhere in their body, hence the disseminated intravascular coagulation. So patients bleeding a lot, but they have a whole lot of active clots. TTP, thrombotic thrombocytopenic purpura. Malignancy can be a cause of that. What's that look like? Well, remember, TTP is our HUS, hemolytic uremic syndrome triad, except it's seen in adults, not kids, and it's got a couple of additional findings. So we're going to see a thrombocytopenia, low platelets. We're going to see an anemia, low red count, and typically that's a microangiopathic hemolytic anemia. We're going to say AKI, acute kidney injury. Your kidneys are going to be hurting because of the clots and all of the red cell lysis. But then in TTP, you will also see fever and you'll see neurologic signs and symptoms. So they could be delocalized to a person, place, or time, or they could just be very lethargic or non-responsive. That's an example of neurologic involvement in TTP. And then finally, arterial thrombosis. Those are pretty rare. If you get one of those, it's a bad. Overcoagulation. So that's clotting in cancer. Now let's go back up and talk about some antiphospholipid syndrome. This is an autoimmunity, and I want you to understand first and foremost that it typically co-presents alongside other autoimmunities. So if you have things like lupus or rheumatoid arthritis, psoriatic arthritis, systemic sclerosis, giant cell arteritis, all of those are autoimmunities. So if you have one autoimmune disorder, you're way more likely to develop another one than someone with no prior history of an autoimmunity. So antiphospholipid syndrome is an autoimmunity that causes you to get a lot of clots. And this can present as the DVT, or it could present as a new onset stroke in a very young person, or pulmonary embolism in a young person, so that suspicious thrombosis. And finally, antiphospholipid syndrome in women does like to present as recurrent fetal loss. So if the mother's had a couple of miscarriages in a row and there's been no obvious reason why, maybe they give you the information that they've done karyotyping and trisomy studies, and those have come back totally normal. You want to get suspicious for a maternal pathology rather than a fetal or placental pathology. And so antiphospholipid syndrome could be a source of a bunch of clotting that obstructs blood flow to the baby, and then there's your abortion. So 3 big tests to recognize and associate with antiphospholipid syndrome, because typically how they will steer you in this direction in a question is to say, oh, well, symptom, symptom, history, history, symptom. By the way, the patient had a positive lupus anticoagulant test, or the patient had a positive anticardiolipin test. And so then that'll, again, lock you on to, okay, now I'm thinking antiphospholipid syndrome or lupus until proven otherwise. So before we get into anything else about the tests, how does antiphospholipid syndrome? So you've got antibodies against phospholipids. Well, that kind of sucks because phospholipids are in every single cell in your body. I mean, find me a cell without phospholipids. You can't. So you've got antiphospholipid antibodies. How does that promote clotting? Number 1, tissue factor gets upregulated. We took a look at what that can do. Number 2, platelets get activated by these antibodies because they're phospholipids in the membranes of platelets too, okay? And number 3, complement is going to get activated by these antibodies. If they're IgG or IgM, they can activate complement and get it to aggregate on some blood cells and endothelial cells. That's really bad. Complement's going to poke a hole in those cells. So getting back to the presentation, DVT, common presentation, pregnancy morbidity, the second time that's been introduced. Livedo reticularis means that you've got a medium vessel vasculitis essentially. And so sources of vasculitis can be numerous. And one of them could just be overactivation of clotting, leading to some hypoxia, right? Okay, now you've got some backup of waste products throughout these blood vessels. And so you're going to see necrosis first in the distribution of the blood vessels and then everywhere else. Leg ulcers, pregnancy complications, third time that that's been mentioned, so wouldn't be surprised if that's on our immediate exam about this topic. Here we go. This is the section I wanted to get to. Laboratory studies. So anticardiolipin antibodies are responsible for the false positive VDRL test in lupus patients. And remember, a false positive treponemal test is a diagnostic criteria for lupus. How many do you need? Well, how many are there? There's, I think, 11, maybe 12. So how many do you need to make the diagnosis of SLE? You need 4. And 3 would be probable lupus, but not confirmed. Now, one of those diagnostic criteria is false positive treponemal test. So patients with lupus have anticardiolipin antibodies. Patients with antiphospholipid syndrome often have anticardiolipin antibodies. So there's some overlap there. So technically they're 2 different autoimmunities, but they can present side by side. Then you have these anti-beta 2 GPI antibodies. Just know the name. And finally, we have lupus anticoagulant. Patient with antiphospholipid syndrome will have positive lupus anticoagulant test, meaning that they will have a prolonged PTT, partial thromboplastin time, that does not correct whenever you put some normal blood into this patient's blood. It's going to take a little bit to break apart. Okay, so first, you've got antiphospholipid antibodies. Does that make sense? Yes, it does. Second, you've got an extended partial thromboplastin time, PTT. Does that do to the intrinsic or the extrinsic pathway? That does the extrinsic pathway. So third, if your extrinsic pathway is taking a long time to work, check this out. intrinsic, PTT intrinsic pathway. If your intrinsic pathway is taking a long time and you've got antiphospholipid antibodies, look at this. PL. What does that mean? Oh, that means phospholipid. So at activated factor 9, right here at the end of the intrinsic pathway, you need phospholipids to go on and activate factor 10 to let the intrinsic pathway do its job, finish its work. So if you have antibodies against free phospholipids, it's going to be tougher to activate that intrinsic pathway. Does that make sense? I hope so. Makes a lot of sense to me. Again, right there it is, phospholipid. You need phospholipids to seal the deal, to put the wax on the intrinsic pathway, to put the letter in the mailbox. And if you don't have phospholipids, that intrinsic pathway, PTT, is really drawn out. It takes a long time for that intrinsic pathway to work. And in this autoimmunity, because there are antibodies to phospholipid in the serum, you can put somebody else's blood. You can mix somebody else's blood in with this patient's and it still won't clot. Why? Because the patient's antiphospholipid antibodies will react against the donor's phospholipids as well. So that's why you have a prolonged PTT and positive lupus anticoagulant test whenever you have antiphospholipid syndrome. So takeaway with antiphospholipid, please remember the 3 tests. Please remember the lupus correlation. Please remember that pregnancies do tend to be complicated because of that. And other than that, treatment and stuff is a step 2 and 3 type thing. Pregnancy. Pregnancy makes you more likely to get a clot. Well, all 3 components of Virchow's triad are present at some point in pregnancy. You've got stasis of the lower extremities because the uterus is going to compress inferior vena cava as well as iliac veins. You've got endothelial injury, particularly during delivery. And finally, you've got hypercoagulability because you're going to be upregulating hepatic production of clotting factors thanks to estrogen, which is going to keep going up for a long time during pregnancy. So all clotting factors are made by your liver except for von Willebrand factor. Got that? Which is like a cofactor 8. It's a complex of cofactors with factor 8. So everything but von Willebrand factor is made in your liver. So anything that gets your liver making proteins is going to cause the production of more clotting factors. And then on the flip side of that, cirrhosis, hepatitis, any other hepatic pathology is going to cause a decrease in clotting factor synthesis because your liver is going to be hurt and fibrotic. What's another organ system that if it's dysfunctional is going to cause you to waste clotting factors? Don't say respiratory. Don't say neuro either. It's not that. No. It's renal. It's renal. If you've got a nephrotic syndrome and your glomerular basement membrane looks like Swiss cheese, your clotting factors are going to be going out in the toilet every time you pee. Okay. So never forget about nephrotic syndrome as a source of protein wasting. And then OCPs, oral contraceptives, almost always have some estrogen component. They used to be almost all estrogen. Now it's about a 20-to-1 progestin estrogen ratio. And we think it's largely the estrogen component that's responsible for the increased clotting that you see when you're on an OCP. But we understand that the progestin part plays a little bit of a role too. And this is the reason why OCPs are totally contraindicated in women who have a heavy smoking history, because smoking is an endothelial poison and endothelial wall damage is one of the 3 components of Virchow's triad that's going to get you to clot. So you can't put someone on an OCP while they're smoking. And contraceptives increase hepatic production of procoagulants, but they also decrease the hepatic production of anticoagulants. And I want you to think about it this way. Oral contraceptives are basically antagonists to heparin, because we said Heparin's the coach, antithrombin's the player. Heparin just gets antithrombin and speeds it up and makes it better. So OCPs inhibit antithrombin. They're antagonistic to heparin. That's not literally their only role, but you can think of them in that manner. So there's one other drug that acts very similarly to estrogen and the oral contraceptives in that it gets you to start upregulating clotting factors, and that's desmopressin. And desmopressin is actually going to upregulate factor VIII specifically. So it's a very good thing to use if patients got something like hemophilia. You know, hemophilia A has a factor VIII deficiency. Von Willebrand disease has a little bit of a factor VIII deficiency because, again, von Willebrand factor is a cofactor for activation of factor VIII. So you can use desmopressin in patients with hemophilia or VWF disease in order to get their factors a little bit up. Now we've got heparin-induced thrombocytopenia. So you give somebody some heparin, you slap some heparin on them, you think, okay, they're not going to clot, and then they end up clotting. That's what this is. So why do they clot? Well, you start making antibodies against platelets. Okay, well, why do they clot? Because the antibodies activate the platelets. Oh, okay, I got it. That's why they clot. So then why do you make these autoantibodies? Well, it's specifically because of this thing called platelet factor 4. Heparin plus, all right, so heparin doesn't make you make antibodies. Platelet factor 4, that thing is benign, that thing is sterile. You will never make an antibody to platelet factor 4 on its own. But platelet factor 4 plus heparin, ding, ding, ding. Now you're making some IgG against that sucker. And you start making IgG and it latches onto platelets and they clump together. That's it. So treatment for this is going to be a factor 10 inhibitor, rivaroxaban, argatroban, bivalirudin, and mortality of 20 to 30%. So you need to be very suspicious of this. If a patient is on heparin, how's it going to present? Well, even though they have thrombocytopenia, it's not really a bleeding condition. It's a I'm clotting everywhere condition. So pulmonary embolism, DVT, two most common presentations. You can see arterial clots. It's a lot less likely, but that could lead you to an MI or thrombotic stroke or limb ischemia or even a renal embolus. And now we're at the last pathology that we'll talk about today. This is hyperhomocysteinemia. You've got a lot of homocysteine in the blood. So how do you make homocysteine normally? You make it with the help of B12. B12 takes a methyl group from B9. This 5-methyl tetrahydrofolate down here is vitamin B9, that's folate. And so whenever folate's getting recycled, it wants to go back to having 0 methyl groups on it. That's its tetrahydrofolate stage. And to do that, it just takes its methyl group and gives it to B12. So then B12 is like, okay, well, I need to get rid of this methyl group so that I can help folate out one more time. So where does B12 take its methyl group? And the answer to that is it puts it on methionine. I'm sorry, it puts it on homocysteine to make methionine. So homocysteine just jogs by B12 and grabs its methyl group, and now it's methionine. So any B12 deficiency automatically is going to give you homocysteinemia. Got it? Any B9 deficiency, any folate deficiency, you don't have any folate? Okay, well then that means that even if you have B12, it's unable to get methylated. So you're still going to have a lot of homocysteine. That's why homocysteine is up in B9 and B12 deficiency. What's the test that we use to differentiate between the two? Methylmalonyl-CoA, methylmalonic acid. There we go. MMA, that's up in B12 deficiency. But homocysteine is up in B12 and B9 deficiency. So there's 2 acquired causes of hyperhomocysteinemia and then 3 familial causes that we'll talk about now. three enzymes that can be out, namely. And I'd like to draw your attention to this one page in first aid. It's, I don't have it open. It's like page 84 or something like that. It's in the biochemistry section talking about homocysteinuria. This is where you want to be because this section of the SDL corresponds to this section of first aid. So going through the SDL, we got this nice chart we can refer back to. We've got a little bit of exposition about homocysteine. It's a toxic molecule. It causes endothelial damage. It leads to atherosclerosis, and it predisposes to clots, which is why it is in this SDL on hypercoagulable diseases. Now, homocysteine can be eliminated by the body through three different pathways. And so I want to point out to you that this is why first aid goes into detail about, oh, you need to give this patient with this enzyme deficiency B6, or you need to give this patient cysteine in their diet. It's because B6 is a cofactor that you need to get cysteine, homocysteine, out of the body. You need to run it through a transaminase, okay? Because homocysteine is an amino acid. And if homocysteine is toxic and you want to metabolize it to something else, because it's an amino acid, you need a transaminase to make it into something else. And so what's the cofactor for all transaminations? That would be pyridoxal phosphate, B6, which is the same thing that gets depleted in isoniazid therapy. So getting rid of homocysteine depletes B6. It's a good idea to get these patients on some dietary B6. That'll come up again in this SDL. If you see it, that's why. Now, homocysteine, again, just gets turned into cysteine. Transsulfuration, that's one way to get rid of it. You could also get rid of it with methionine synthase. Some people miss that enzyme, and that'll just pump out methionine on the other side with a B12 cofactor. And then finally, you could run it through betaine homocysteine S-methyltransferase to make some more methionine through that pathway. So some different ways to get rid of homocysteine if it's elevated in the blood. Most of them involve B6, supplement B6, moral of the story. Causes of hyperhomocysteinemia. Again, three heritable causes: B12, B9 deficiency. There we go. Now we're going to talk about the enzymatic defects. First off, you could have a methyl tetrahydrofolate reductase deficiency, which is going to lead to increased blood homocysteine and increased 5,10-methyl tetrahydrofolate. So this is usually due to missense mutations. Don't think that's too important. There is no megaloblastic anemia. That's important because one of these three enzyme knockouts does give you a megaloblastic anemia, so it's not this one. And also, a methyl tetrahydrofolate reductase knockout does not lead to a folate or a B12 deficiency. So we go up here, we look at methyl tetrahydrofolate reductase. Here's where it is. It takes 5,10-methyl THR or THF to 5-methyl THF. And even if this enzyme is knocked out, you can still get rid of 5,10-methyl tetrahydrofolate by this enzyme thymidylate synthase, which takes DUMP, converts it to deoxythymidine monophosphate in your nucleotide synthesis pathway. It takes that 5,10-methyl tetrahydrofolate, turns it back into dihydrofolate. So you can get, you're not going to have any enzyme buildup, or rather metabolite buildup, if you have a methyl tetrahydrofolate reductase knockout. Now, what's the enzyme, or what's the drug that we give, rather, that inhibits thymidylate synthase? That'd be 5-fluorouracil, right? And then methotrexate is going to be acting a little bit upstream around the same pathway here, working on our dihydrofolate reductase right there, taking it to tetrahydrofolate. That's where methotrexate would come into play. So that's the way to get your bearings whenever you're working with B9, B12. Figure out where methotrexate and 5-fluorouracil would be, and then the rest of it kind of maps itself out. So our second enzyme mutation is memorable. It's a methionine synthase deficiency. It'll give you a megaloblastic anemia. Let's go back and look at the chart. Here is methionine synthase. Let me go to blue. So methionine synthase is what gives B12's methyl group to homocysteine to make methionine. Now, if you're missing this enzyme, B12 is stuck holding a methyl group. What that means is it can no longer accept a methyl group from folate. So that's a folate trap. That's a bad folate trap because you're going to get a ton of 5-methyl tetrahydrofolate and everything is just going to keep going down into there and it's going to get stuck. That's a methyl trap. So that's a megaloblastic anemia because you will eventually get folate deficient. And then number 3, you could have a cystathionine beta synthase deficiency. This is your classical homocysteinuria, which is going to present with elevated urine homocysteine as well as a marfanoid habitus, ectopia lentis, dislocated lens. It's going to be down and out. And arachnodactyly, early thromboses. So pulmonary embolism, stroke, potentially coronary artery, myocardial infarction. Does tend to be young in life because finally homocysteine is an endothelial toxin and all endothelial damage predisposes you to formation of a thrombus. So wrapping up homocysteinemia, you've got 3 types, 3 different enzymes, really. You got more than 3 types. So you can have acquired or familial hyperhomocysteinemia. Acquired would be a vitamin deficiency, B6 or B9 or B12, and then familial would be due to a deficiency in one of 3 enzymes: cystathionine synthase, methionine synthase, or methyl tetrahydrofolate reductase. And those all have their own lab findings. Understand that 5,10 methyl tetrahydrofolate is up in a methyl tetrahydrofolate reductase deficiency. Man, why do these words have so many syllables? And there's no megaloblastic anemia in 2 out of the 3. In a methionine synthase defect, you do have a megaloblastic anemia, which is macrocytic. So your MCV is like 102 or 105 or 110, something like that. And cystathionine synthase deficiency, last one we'll talk about, that classic presentation with the marfanoid habitus. Patient's tall, slender, has a lens dislocation, early thrombosis, early atherosclerosis. And that is the conclusion of my talk on coagulopathies. Thanks a lot. See you next time.